Dr. Aurangzeb, and today I am presenting in brief few of the important late-breaking trials presented during the European Society of Cardiology 2021 e-Congress. If you are new to my channel and have interest in cardiovascular education, I will request you to please subscribe to the channel. Also, please consider liking, sharing and commenting as it helps immensely. So let's begin our video. Okay, so the first trial that I have chosen for this talk is the Tomahawk Trial, that is immediate angiography after out-of-hospital cardiac arrest without ST segment elevation. The impact of this trial on clinical practice, as we know that the usefulness of coronary angiography in survivors of out-of-hospital cardiac arrest without ST segment elevation is not certain. An acute MI is the cause of cardiac arrest in about 1/3 of the patients. Therefore, diagnostic coronary angiography and PCI, if needed, could be beneficial. The clinical rationale behind the Tomahawk trial was to address the hypothesis that routine immediate coronary angiography is superior to a deferred or selective approach regarding 30-day all-cause mortality in resuscitated patients with out-of-hospital cardiac arrest without ST segment elevation. The study objectives. The trial examined whether immediate coronary angiography for treating or ruling out acute MI in survivors of out-of-hospital cardiac arrest without ST segment elevation is beneficial for all-cause mortality at 30 days compared with initial ICU assessment and delayed selective angiography. So in this slide, the whole summary of the trial will be presented. How was the study performed? So the study population included patients who were 30 years or older, who were successfully resuscitated after out-of-hospital cardiac arrest, and there was a possible cardiac cause of arrest, and there was no ST segment elevation on post-resuscitation ECG. Patients who had shockable and non-shockable rhythms were included in the trial. So it was a multi-center trial with 554 patients with successfully resuscitated out of hospital cardiac arrest who were randomized. All the patients had no evidence of ST segment elevation on post-resuscitation ECG. A total of 256 patients were included in the primary analysis in each group. So the 554 patients were randomized in a 1-to-1 fashion to two groups, those with immediate coronary angiography and the patients who were initially assessed and stabilized in the ICU, followed by delayed and selective angiography. The main intervention that was performed during the study was immediate angiography versus delayed angiography, admission to the intensive care unit, coronary angiography after a minimum delay of 24 hours after cardiac arrest. The primary endpoint was all-cause mortality at 30 days. The secondary endpoints included all-cause death or severe neurological deficit at 30 days. The results. The Tomahawk trial found that among patients with resuscitated out-of-hospital cardiac arrest with a possible cardiac cause without ST segment elevation, an immediate coronary angiography strategy was not found to be beneficial over a delayed or selective strategy with respect to the 30-day risk of death from any cause. So early angiography was not superior to delayed or selective approach. We can see here that 54% of the patients in the early angiography group compared to 46% of the patients who initially were stabilized and then had a delayed or selective angiography died after 1 month. There was no difference between the two in the various pre-specified subgroups, including patients with shockable and non-shockable rhythms. The composite secondary endpoints were more frequent in the immediate angiography group. We can see that the relative risk was 1.16 for immediate angiography group patients. So in conclusion, early angiography in out-of-hospital cardiac arrest patients without ST segment elevation is not superior to delayed assessment and selective angiography. And finally, the current trial findings support the results from the randomized coronary angiography after cardiac arrest COACT trial, which also showed no significant differences in clinical outcome among patients with out-of-hospital cardiac arrest between immediate and delayed coronary angiography at 90 days and at 1 year. The next trial which I have chosen for this talk is the IAMI trial, that is influenza vaccination after acute myocardial infarction trial. The impact of this trial on clinical practice: as we already know, more people die from cardiovascular causes during influenza epidemic than during the non-epidemic periods. Flu shots are recommended for patients with heart diseases such as coronary artery disease and congestive heart failure, but vaccination is still not part of standard hospital care following an acute MI. The goal of the trial was to assess the safety and efficacy of influenza vaccination among patients with recent myocardial infarction or high-risk coronary disease. Therefore, the study objectives were set and the trial was designed to evaluate whether influenza vaccination improves outcomes following MI or PCI in high-risk patients with coronary artery disease. In this trial, I will summarize the trial. This trial was conducted in 30 hospitals of 8 countries. Between 2016 and 2020. Patients with recent myocardial infarction or percutaneous coronary intervention were randomized in a 1:1 double-blinded fashion to either influenza vaccination or saline placebo. The total number of patients selected for the trial were 2571, and when they were randomized in a 1:1 fashion, 1272 patients received the influenza vaccination, the flu vax, and 2060 patients received saline placebo. The inclusion criteria for this trial was that all patients must be 18 years or above, and they are admitted with ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction with completed coronary angiography or PCI, and patients with stable coronary artery disease more than 75 years of age with additional risk factors. However, certain group of patients were excluded from the trial, including patients who recently received the influenza vaccination, intention to be vaccinated during the ongoing influenza season, or had severe allergy to eggs or previous allergic reaction to influenza vaccine, patients who suffered from febrile illness or acute ongoing infection, endogenic or iatrogenic immunosuppression. All these patients were administered with the flu wax within 72 hours of PCI or hospitalization. The primary endpoints of this study was a composite of all-cause death, MI, or stent thrombosis at 12 months. And the secondary outcomes and endpoints were all-cause death, cardiovascular death, and myocardial infarction. The primary outcome, a composite of all-cause death, MI, or stent thrombosis for influenza vaccination versus placebo, was 5.3% versus 7.2%, with a hazard ratio of 0.72, 95% confidence interval 0.52 to 0.99, with a significant p-value. The secondary outcomes for influenza vaccinations versus placebo were that all-cause death was 29% versus 4.9%, with a significant p-value. Cardiovascular death was 2.7% versus 4.5%, and MI was 2% versus 2.4%. The results of this trial indicate that influenza vaccination within 72 hours of angiography, PCI, or hospitalization among patients with recent MI or high-risk coronary heart disease resulted in a salutary effect on cardiovascular outcomes at 12 months compared with placebo, including lower risk of all-cause and cardiovascular mortality. So in conclusion, we can see and we can say that influenza vaccination reduces the risk of all-cause death, MI, or stent thrombosis at 12 months in hospitalized patients with MI or high-risk coronary disease. The third trial which I have chosen is the Master DAPT trial, the DAPT after coronary stenting in high bleeding risk patients. We know that the duration of dual antiplatelet therapy in patients with high bleeding risk is unclear. Guidelines recommend shortening the duration of DAPT in these patients to 6 months or less, or even 1 month. The recommendation that I have talked is a level of evidence C. The goal of the trial was to evaluate abbreviated antiplatelet therapy compared with standard antiplatelet therapy among patients who underwent percutaneous coronary intervention with biodegradable polymer sirolimus-eluting stent. To assess whether 1 month of dual antiplatelet therapy preserved the benefit in relation to cardiovascular events while mitigating bleeding outcomes compared with longer treatment durations, this was a non-inferiority study with sequential superiority testing. Participants with symptomatic coronary artery disease who underwent PCI within the previous 30 to 44 days were randomized to an abbreviated therapy group. Number of patients included in this group were 2,295 versus a standard therapy group. The number of patients in this group were 2,284. The inclusion criteria for this trial was that patients included who had acute or chronic coronary syndrome at high risk of bleeding and underwent PCI of all coronary artery stenosis with biodegradable polymer sirolimus-eluting stents. Patients free from ischemic and bleeding events and who adhered to a DAPT regime were screened for inclusion 30 to 44 days after PCI. Patients enrolled in about 30 countries. Total number of patients, we already talked, were 4,579. They were randomized in a 1-and-1 fashion, a median of 34 days after PCI into 2 groups. Patients with the one group of patients received the standard dual antiplatelet therapy, continued DAPT for at least 5 additional months. Patients receiving anticoagulants took DAPT for another 2 months and continued afterwards with a single antiplatelet agent. And the other group was the abbreviated dual antiplatelet therapy group. who immediately discontinued dual antiplatelet therapy and single antiplatelet agent till the completion of the study was initiated in these patients. Some patients were excluded from this trial, including patients who have implantation of a non-ultimaster stent within the prior 6 months, implantation of a bioresorbable scaffold before the index procedure, and treatment of an in-stent restenosis or stent thrombosis. Complete follow-up date at 335 days were available for 4,567 patients data. One group of patients who had no adverse clinical events, the composite of all-cause mortality, MI, stroke, and major or clinically relevant non-major bleeding. Net adverse clinical events, that is all-cause mortality, MI, stroke, or major bleeding, was 7.5% in the abbreviated therapy group compared with 7.7% in the standard therapy group. P-value of less than 0.001 for non-inferiority. Abbreviated depth was non-inferior to standard dual antiplatelet therapy. So this was no adverse clinical events. Adverse clinical events included major cardiac and cerebral bleeding events, composite of all-cause death, MI, and stroke, was 6.1% in the abbreviated arm versus 5.9% in the standard arm. Abbreviated dual antiplatelet therapy was non-inferior to standard dual antiplatelet therapy. Major or clinically relevant non-major bleeding occurring between randomization and 335 days, BARC 2, 3, or 5. 6.5% in the abbreviated arm versus 9.4% in the standard arm, and clearly the abbreviated dual antiplatelet therapy was superior to the standard dual antiplatelet therapy. Net adverse clinical events for abbreviated versus standard therapy among those with an indication for oral anticoagulation therapy, relative risk was 0.83. Net adverse clinical events for abbreviated versus standard therapy among those without an indication for oral anticoagulation therapy, the relative risk was almost the same, 1.01. Major adverse cardiac and cerebral events for abbreviated versus standard therapy among those with an indication for oral anticoagulation therapy. Again, here there was a benefit with the relative risk reduction of 12%. Major adverse cardiac and cerebral events for abbreviated versus standard therapy among those without an indication for oral anticoagulation therapy. It was just about similar between the two groups. So we can interpret from the data that among patients with acute or chronic coronary artery disease who underwent PCI within the last 30 to 44 days and were at increased bleeding risk, abbreviated dual antiplatelet therapy was non-inferior to standard dual antiplatelet therapy regarding net adverse clinical events and major adverse cardiac or cerebral events. Abbreviated dual antiplatelet therapy was superior to standard antiplatelet therapy regarding major or clinically relevant non-major bleeding. These results are specific to patients who receive a biodegradable polymer sirolimus-eluting stents. The results were the same among those with and without an indication for oral anticoagulation therapy. Again, with the conclusion is that 1 month of dual antiplatelet therapy following stent implantation in high bleeding risk patients preserved ischemic benefits and reduced bleeding risks. ENVISAGE-TAVI AF trial, that is Addoxaban versus vitamin K antagonists after TAVI in patients with atrial fibrillation. The prevalence of pre-existing or new onset atrial fibrillation after TAVI ranges from 20 to 40%, and oral anticoagulants are recommended to prevent stroke in patients with atrial fibrillation. However, little is known about the safety and efficacy of DOACs versus vitamin K antagonists after TAVI. Therefore, the goal of the trial was to assess the efficacy and safety of Addoxaban compared with vitamin K antagonists among patients undergoing transcatheter aortic valve replacement with either incident or prevalent atrial fibrillation. So the study objectives: to compare the safety and efficacy of DOAC Addoxaban with vitamin K's antagonists in patients with AF with an incident or with an indication for oral anticoagulants after successful transcatheter aortic valve implantation. This is the main slide. The trial was conducted in 14 countries, spanned 3 continents and 173 medical centers worldwide. Eligible patients were randomized in an open-label 1:1 ratio fashion to either 60 mg Addoxaban daily or vitamin K antagonists with an international normalized ratio goal of 2:3. A total number of 1,426 patients with AF were included in the study. 713 were randomized into the Addoxaban group and 713 into the vitamin K antagonist group. The therapy in both groups was started between 12 hours and 5 days after successful TAVI. Specified antiplatelet therapy in either trial group was allowed at the treating physician's discretion, including dual antiplatelet therapy for up to 3 months after TAVR or single antiplatelet therapy indefinitely. The average follow-up duration for the trial was 18 months. Inclusion criteria included the patients included in the trial were 18 years and above, had successful TAVR without unresolved peri-procedural complications, and had prevalent or incident AF. The composite of adverse clinical events, including all-cause death, AMI, ischemic stroke, systemic thromboembolism, valve thrombosis, and major bleeding, and primary safety endpoints included incidence of increased major bleeding. So, with regard to the primary efficacy outcomes, all-cause mortality, myocardial infarction, ischemic stroke, systemic thromboembolic events, valve thrombosis, or major bleeding for Addoxaban versus vitamin K antagonist was 17.3 per 100 person year versus 16.5 per 100 person year, with a hazard ratio of 1.05. With regards to the primary safety endpoints, major bleeding was 9.7 per 100 persons year versus 7 per 100 person year with a hazard ratio of 1.40. Okay, so that was increased risk of bleeding compared to vitamin K antagonist group was mainly due to gastrointestinal bleeding loss. The patients who required a downward dose adjustment and those not prescribed oral antiplatelet therapy had a similar rate of major bleeding compared to vitamin K antagonists. Secondary outcomes for Addoxaban versus vitamin K antagonists was that all-cause mortality was was 7.8 per 100 persons year versus 9.1 per 100 person year. Ischemic stroke was 2.1 per 100 person year versus 2.8 per 100 person year, and intracranial hemorrhage was 1.5 per 100 person year versus 2.1 per 100 person year. Before going on to conclude, the results of this trial indicate that Addoxaban is non-inferior to vitamin K for efficacy but did not meet criteria for non-inferiority for bleeding among patients undergoing TAVI with AF. Bleeding events, primarily gastrointestinal bleeding events, were higher. There were no clinical valve thrombosis events. These results are overall similar to data with Addoxaban among patients with AF but not undergoing TAVI. The higher bleeding rates are likely a reflection of the population enrolled, elderly and frail with multiple comorbidities. In the Galileo trial, low-dose rivaroxaban had worse outcomes compared with antiplatelet therapy among patients undergoing TAVI and who did not have an indication for oral anticoagulation. In the Atlantis trial, apixaban was superior to vitamin K antagonists in reducing valve thrombosis on 4D computed tomography among TAVI patients who had an indication for oral anticoagulation but had similar clinical outcomes. Among patients who did not have an indication for oral anticoagulation, non-cardiovascular mortality was higher with apixaban compared with antiplatelet therapy use. So in conclusion, we can say that Addoxaban is non-inferior to vitamin K antagonists and is analogous for adverse clinical events in patients with atrial fibrillation after TAVI. The incidence of major bleeding is high with Addoxaban. Finally, the EMPEROR-PRESERVE trial. The effect of empagliflozin on cardiovascular death and heart failure hospitalization in patients with heart failure with preserved ejection fraction with and without diabetes. The most important trial, in my opinion, and potentially a landmark trial that was presented during the ESC Congress. The goal of the trial was to assess the safety and efficacy of empagliflozin in patients with symptomatic heart failure with preserved ejection fraction irrespective of their diabetes status. The background of the trial can be described as, we know that from the EMPEROR-REDUCE trial, which was previously conducted, showed that the SGLT2 inhibitor empagliflozin reduced the risk of cardiovascular death or hospitalization in patients with heart failure with reduced ejection fraction. The study objectives were to the EMPEROR-PRESERVE evaluated the effects of sodium glucose transporter 2 inhibition in heart failure with preserved ejection fraction patients with and without diabetes. Main slide. The study was conducted in 622 centers of 23 countries. 5,988 patients with symptomatic heart failure with preserved ejection fraction were included in the trial. The inclusion criteria include patients who were 18 years or old, had chronic heart failure, NYHA functional class 2, 3, and 4, preserved ejection fraction defined as ejection fraction greater than 40%, who had heart failure hospitalization within 12 months, and their NT-proBNP level was 300 or more picogram per ml without atrial fibrillation and more than 900 picogram per ml with atrial fibrillation. Structural heart disease within 6 months or documented heart failure hospitalization within 12 months. Stable dose of oral diuretics if prescribed. All these patients were randomized in 1:1 fashion to empagliflozin or placebo on top of all appropriate treatment for heart failure with preserved ejection fraction and comorbidities. The median follow-up for the study was 26 months. Patients excluded from the trial were those patients who had acute coronary syndrome, stroke, or transient ischemic attack within 90 days, listed for orthotopic heart transplantation, or had received a transplant, acute decompensated heart failure, systolic blood pressure greater than or equal to 180 millimeters of mercury, symptomatic hypotension or systolic blood pressure equal to or less than 100 millimeter of mercury, liver or kidney disease, current use or prior use of SGLT2 inhibitors or combined SGLT1 and 2 inhibitors. The primary endpoints included composite of cardiovascular death or hospitalization for heart failure. The secondary endpoints were hospitalization for heart failure and rate of decline in GFR during the study treatment. Serious adverse events. They occurred in 47.9% in empagliflozin group versus 51.6% in placebo arm. The primary outcome, that is cardiovascular death or heart failure hospitalization for empagliflozin versus placebo, was 13.8% versus 17.1%, a hazard ratio of 0.79. Cardiovascular death 7.3 versus 8.2% with a hazard ratio of 0.91. Heart failure hospitalization significantly less with empagliflozin compared to placebo with 8.6% versus 11.8%, hazard ratio of 0.71. For the primary outcome, the benefit was similar among patients with or without type 2 diabetes. The benefit appeared somewhat attenuated among patients with ejection fraction equal to or greater than 60%. Total hospitalization were 407 for empagliflozin versus 541 for placebo. Change in mean eGFR slope was minus 1.25 compared to minus 2.62, and composite renal outcomes 3.6 versus 3.7%. Significantly less reduction with EMPA compared to placebo. The results of this trial indicate that empagliflozin is superior to placebo in improving heart failure outcome among patients with symptomatic stable heart failure with preserved ejection fraction, irrespective of diabetes status. The benefit is primarily driven by a reduction in heart failure hospitalization and not mortality. There was also a benefit in eGFR, but not in renal outcomes per se. The benefit appeared somewhat attenuated among patients with ejection fraction greater than 60%. So we can say that even though the SGLT2 inhibitors were introduced as type 2 diabetes management drugs, the results of EMPA-REG outcome, EMPEROR reduced, and others indicated a clear benefit in heart failure management. This trial enrolled a dedicated heart failure with preserved ejection fraction population and shows a benefit in this patient population irrespective of diabetes status. Most routinely used drugs for heart failure with reduced ejection fractions have not shown to be effective among patients with heart failure with preserved ejection fraction, and some drugs such as candesartan, spironolactone, and sacubitril, valsartan, Entresto appears to mostly have benefit among patients with ejection fractions between 40 and 49% rather than true heart failure with preserved ejection fraction. The exact mechanism of benefit is unclear. The pooled analysis of EMPEROR reduced and EMPEROR preserved suggests that the renal benefits is primarily among patients with heart failure with reduced ejection fraction, and eGFR slope analysis may not be predictive of renal outcomes among patients with heart failure. So, we can conclude that the EMPEROR preserved trial showed that empagliflozin reduces the risk of a composite of cardiovascular death or hospitalization for heart failure in patients with heart failure with preserved ejection fraction with or without diabetes mellitus. Thank you very much.